Welcome to this e-learning module, a preoperative anaemia clinic from the patient's perspective. My name is Sam Timmins and I'm a patient blood management practitioner for NHS Blood and Transplant in the UK, and I'll be guiding you through this presentation. I'd like to take the opportunity to thank Dr Stuart Cleland and Mr Anthony Palmer for sharing their experience and insight in setting up their preoperative anaemia services for the purpose of this presentation. Considering why the patient's perspective is so important is due to healthcare becoming increasingly patient-centred, promoting redesign and innovation of new ways of service delivery. Patient-centred care has been attributed to improve patient outcomes, adherence and greater patient satisfaction. In order to support patient-centred service delivery, the NHS Institute for Innovation and Improvement has identified patient journey mapping as one of the most powerful ways for multidisciplinary teams to understand the process and any potential challenges from the patient's perspective. This presentation will follow a patient's journey through pre-surgical anaemia screening and management. In order to follow a patient's journey, we must first put ourselves in a patient's shoes, and considering the fact that they will have likely had numerous appointments prior to being listed and possibly still have numerous appointments for other treatments and therapies as part of their care plan, how patients will be feeling about not only their surgical procedure but any further investigations and treatment, the fact that these patients are unwell, possibly in pain, and thinking about their personal and social circumstances throughout this process of surgery and pre-surgical anaemia management. We join our patient's journey at the point of screening. Timeliness of screening and identification of anaemia is essential, not only to ensure treatment is given, but the patients have enough time to gain benefit and an optimal haemoglobin rise. Timeliness can also help avoid delays and postponement of surgery should a patient remain anemic or require further investigation. Such delays and changes to care plans can cause further anxiety and stress, reduce a patient's satisfaction of the service delivery, and have a potential negative impact on their overall health and well-being, both mentally and physically, as well as the impact this can have on the efficiency of surgical services and waiting list times. By promoting a collaborative approach with the surgical team and involving them in the development of a pre-surgical anaemia management pathway, it can help adopt screening and identification at the first visit to the surgical team, promoting timely identification and treatment. Collaboration with primary care and adopting identification at the point of referral could not only support timeliness, but might also reduce the number of hospital visits required for patients. Use of HemoQs and other resources can promote patient prioritisation for further samples and screening, and collaboration with laboratory staff and services may help promote timely and appropriate screening of iron deficiency. When communicating appointments to patients, time frame should be considered, ensuring patients have enough time to make arrangements, considering their social needs and their physical needs, especially if they're travelling from a distance, and that mode of communication should reflect that, as well as any hearing or sight impairments they may have or any language barriers. The information we provide to patients at this point in the journey is essential to patient engagement and should be designed to support attendance. Patients are here for surgery and they may need some help and support understanding why screening and treatment for anaemia is an important part of their surgical care plan. Supporting them with information around what to expect, who they will see, along with helpful practical information around location, travel links, patient transport services, contact details can help remove any potential barriers and worries that may prevent a patient attending or cause delay. Thinking about where patients attend for screening, it's important to understand the geographical area you provide surgical services for, especially in tertiary centres where patients are attending from outside of the region, or in particularly rural locations where distance to main hospitals and potentially transport links are limited. Distance and travel can provide real barriers and challenges for patients' attendance. Sometimes even causing them to opt not to engage with pre-surgical anaemia management, or sometimes just causing delays in their appointments. They need to be reorganised to allow planning for travel, support for travel, whether a family member needs to attend, whether they need a carer, whether they need special requirements for their travel arrangements, not to mention patients are travelling at a distance while feeling unwell and in pain. Or it could just be the timing of their appointment isn't appropriate given the distance that they have to travel, and it's something to bear in mind when making appointments for patients. Providing care closer to home can remove some of these challenges and barriers. This can be achieved by using clinical sites that are away from the main hospital and spread out through the region, or by collaboration with referring centres or primary care, asking them to take on some of the screening processes. Considering clinics away from the main site can also help with accessibility issues. The sites tend to be smaller, more easily accessible from car parks and closer to home in terms of travel links. Utilising other clinical areas to provide screening clinics can also help with some capacity and patient flow through the services, again supporting that timely and appropriate identification of anaemia and treatment. And again, considering how we use patient information and communication to support attendants and help them engage with the service. Regarding the practicalities of how we deliver screening and the next steps, it's important to think about roles and responsibilities. If using an existing preoperative assessment team for screening and identification of anaemia, this may well be an additional role and have an impact on their workload and time availability, but also may require further education and training needs to support them in delivering a good service to patients. By assigning specific roles and duties within the team, it ensures continuity of care for patients, reducing the number of healthcare professionals involved, but also ensures patient prioritisation and efficiency of service delivery. In recent discussion webinar following the Prevent trial, Royal Marsden attributed some of their success in recruitment and treatment to the fact that there was a consultant lead present for their pre-surgical assessment clinics. This expedited the decision-making process and any further referrals required. By having clear pathways and those collaborative links with other areas and other teams involved, it also empowers staff members to make the decisions, to follow the pathway, and this improves how they communicate with patients, removing any delays or ambiguity in what steps are to be taken next, whether that's for treatment or further investigation. It's also important to consider communication to the wider team involved, especially if there are requirements for further investigations. This may impact their surgical date and other plans need to be made. And so ensuring everybody's on the same page also improves that communication and planning for the patient. Timely communication, clear communication and concise communication all supports a patient's journey through this process, their understanding, their engagement, but also their decision-making processes. So ensuring it's supported with clear patient information, whether it's a leaflet or a letter, helps them understand the next steps, retain and refer back to information given. Appropriate choice of therapy is at the heart of patient-centred care when it comes to pre-surgical anaemia management. And this will be very much decided based on a patient's past medical history, their time frame to surgery, and the dose should be dependent on the individual patient's clinical needs. Oral iron may reduce the need for further hospital visits and an invasive procedure, but may not be appropriate to optimise a patient in time for surgery. Therefore, IVI may be indicated. Patient information should be given both verbally and in writing in order to support decision-making process and information retention, but also overcome any issues in communication barriers and challenges. The risks and benefits of either therapy should be disclosed in order to ensure that we're gaining fully informed consent and remove any concerns or fears patients may have, and give them the opportunity to ask any questions and be part of the decision-making process. With respect to IV iron administration, considering where and who delivers IV iron can also impact a patient's journey and experience. Use of an existing service, staff will already have experience and policies in place for using IV iron, and there's less training needs. If setting up a new service, it's understanding what training staff will need in order to support a patient's journey and administration of IV iron. Also important to again think about the location of treatment, not just in terms of travel requirements and accessibility of patients, but also thinking around any safety implications. So the Medicines and Healthcare Products Regulatory Agency in the UK and the European Medicines Agency both recommend that IV iron only be administered in the presence of staff trained in life support and where resuscitation equipment is provided. The final stage in our patient mapping process is to follow up. This really is around making sure that patients have received their treatment, that they've had adequate time to respond, and that we've corrected their anaemia appropriately prior to surgery. For those patients where we don't see an appropriate response or they remain anemic and they need further investigation and treatment, it's about ensuring those collaborative processes are in place so that referrals and further treatment are actioned smoothly and succinctly, but also to make sure that we communicate with all elements of the MDT and that any potential for postponing surgery, the risks and benefits are weighed up and communicated appropriately. From a patient perspective, it's about ensuring that staff are supported to make these decisions, that care planning and ongoing care management's in place, and that patients receive the information and have the time and follow-up to support them with compassion and consideration. For locality and ease of access in follow-up processes, and thinking about the number of appointments and travel and distance, do patients need to be in a physical clinical appointment, or is this something that can be done remotely via telephone or video link? The sensitivity of information that needs to be provided at follow-up probably is a factor here, and if it's complicated, if there's next steps, choosing the most sensitive and supportive format is appropriate in the best interests of your patient. Continuity of care here is also really important. Again, if there are next steps, further investigations or referrals, engaging with a healthcare professional a patient is already familiar with will give them a sense of security and assurance in the next steps they're taking, and hopefully remove any confusion and sense of feeling overwhelmed. And thinking about what's next for your service in terms of patient perspective, service audit provides a great way of demonstrating the impact of the care you're delivering and whether you're meeting the needs of your patient demographic. But the best way to hear your patient's voice is by encouraging patient feedback and hearing their lived experiences of accessing your services. In summary, the following should be considered at each step of the patient journey: the logistics of patient attendance and the number of appointments, communication and clear patient information in order to support informed consent, and using established protocols and pathways and promoting collaborative care to ensure a patient-centred approach.